Tonight we have Dr. Beth Torres, who is joining us and is going to talk to you guys about basic training on 12 lead ECGs. And this class is designed from the EMT all the way up to the paramedic level, so hopefully everybody will get something out of it. I am going to turn you guys over to Dr. Torres. Beth,
Okay,
they're all yours.
so hopefully everybody received the handouts with my slide presentation. On the last page of that slide presentation is my email address. So when at the conclusion, if you have additional questions that you want to email me, feel free to do that. You are also welcome to put the questions in the chat. I may try to answer some of those as we go along, but as Greg said, there's a lot of material here that I want to cover, and I will try to allow the last 10 minutes to go back and answer questions that are in the chat. But if you don't want to put them in the chat and would prefer to email me, then you are welcome to do that. And like Greg said, this presentation came out of after the one I did, I think it was back in December, where I did an advanced class on wide complex tachycardia. And a number of the comments in the chat were that they wanted something a little bit more basic. So that's what I've tried to do here. I will ask questions as we go along, and I encourage you to put the answers in the chat. For those of you that are proficient in 12 leads, I ask that you not throw your answer in right away. Give the people that are novice to this a little bit of time to think about the answer and maybe put it in there before you put your answer in. And I certainly welcome your input and feedback. So if you have a burning question that you really want to get answered before I move on, then unmute yourself. But other than that, if you could keep yourself muted, and we can use the chat to interact with this. So hopefully it will all go smoothly for us. Okay, let me see if I can get it to advance. Oh, and that's my first thing. It's not advancing. Oh, there we go. All right, so these are my objectives, and these are the same ones that are written in your handout. So we'll talk about, even at the very basic level, of why we should do a 12 lead, and then look at how to do it and how to acquire it. How are you going to do the 12 lead? How are you going to do a 15 lead, which would include the right side and the posterior aspects. We're going to look at some common cardiac rhythms. So for those of you that are just learning rhythm interpretation and looking at your monitors, I'm going to throw out some of those in which you, predominantly the ones that you might have hemodynamic compromise. So we'll look at those, and then we will get into some more advanced stuff with looking at MIs and identifying patterns of ischemia, injury, and infarction. So just to kind of give you a little bit of background, cardiovascular disease is the #1 killer in the United States. 1 in 3 people have some form of coronary artery disease. It is fatal in about 370,000 cases, and half of those occur within the first hour of signs and symptoms. And you've heard about how we want to get people in fast and get them to call you quickly so that you can interact with them and start treatment and triage quickly. In the US, about 805,000 people have heart attacks. Oh, I left out the percentage there. And I apologize, I didn't update that with the latest statistics. I had I think 2020 statistics in there. But there's a lot of people that have that first time heart attack. And if they've had a previous heart attack, those are the patients that you can say, how is this the same or different than what you experienced before? And then you also will have those patients that, they don't have the chest pain, or it's a silent heart attack, and it's actually diagnosed because maybe they go into heart failure and we find out, oh, well, you've had an MI in the past. So for the pre-hospital, the reason why an ECG is so important is it can help with a definitive diagnosis. It also helps with triaging the patient. Are you going to take them to the closest ED, or are you going to take them somewhere that has PCI or fibrinolytic capability? It also allows you to have early ED notification. If you can send those ECGs ahead of time, then they can look at that and see what is going on with your patient. And by having that ECG in your hand when you walk through the door, it expedites that door to treatment time. And, you always hear, time is muscle. And so we want to improve our outcomes by getting that patient quickly to the cath lab if they qualify for that. And if we can restore blood flow, then we can hopefully decrease morbidity and mortality in this group of patients. So when you look at the ECG, what it gives you is multiple views of the heart. And it also gives us lots of different information. We can tell, is there a bundle branch block? We can look at the ST segments and T waves to determine, do they have ischemia, injury, or infarction? And we can also diagnose other abnormalities from this, maybe digitoxicity or hyperkalemia. Those are some of the things that can change your patient's ECG. And we'll talk about a few of those today, and I'll show you some ECGs. A couple of MI facts related to ECGs. The ECG is only going to be diagnostic in about 25 to 50% of your patients. For the rest of your patients, it's going to be based on symptoms. Do they have a good story? What does their clinical presentation look like? And the other caveat that you have to be careful of is, how the monitor gives you, the monitor reads out their diagnostic error rate's about 50%. So that's why you might have the ECG, but you also need to look at the patient to say, okay, does the patient look like this? The monitor's saying he's having an MI, or the monitor's saying this, but the patient doesn't look like that. And I'll show you an ECG that illustrates that later. So I want to start off very basic here. For those of you that understand the electrical system of the heart, this will be a review for you, and hopefully you can see my pointer here. The SA node is up here in the right atria, and that's where the impulse starts. So when you're looking at ECGs, keep in mind that's telling us electrical activity in the heart. It does not tell us mechanical activity. That's the clinical correlation that comes in. But the impulse starts up here in the SA node. That's the primary pacemaker of the heart. And then from there, it sends the impulse over to the left atria so that we have atrial contraction on the right and the left side simultaneously. And then it sends the impulse down through these intranodal pathways to the AV node. And then the AV node gets the impulse, holds onto it, allows time for the atria to contract, and then sends the impulse down through the ventricles. Now, the next picture I think has a little bit better picture of the bundles, but here's your bundle of His. This is your right bundle branch, and this just shows one fascicle on the left side of the heart. So what I want to show you down here in this picture is, here's your AV node, and you can see here the difference. This is more drawn anatomically correct. This is your posterior fascicle of the left ventricle, and you can see how thick it is. And then the anterior fascicle is right here, and that's thin. And then you've got your septal fibers that branch off of this left bundle branch, and then you've got your right bundle branch here, and you can see here on the right side that those are very thin. All right. And as I had mentioned about the SA node, that's the intrinsic pacemaker of the heart, or inherent pacemaker of the heart, and it should be sending out impulses between 60 and 100 times per minute. And then here's your AV node, and it serves like a gatekeeper. So it holds onto the impulse, allows the atria to contract so that you don't lose your atrial kick. And that's part of the challenge that you have in patients that go into a fib, is they lose the synchrony between the atria and the ventricle, and they can lose up to 20% of their cardiac output. So the electrical activity has a strong impact on the mechanical activity, which then impacts your hemodynamics that your patient experiences. And I mentioned the bundles here. So when we're looking at the right bundle, as I mentioned, it's thin, it travels down, it's much more fragile, and you're probably more likely to see patients that develop a right bundle branch block than a left bundle branch block. It also has a single blood supply. It's fed by the left anterior descending artery. So if you have a patient that has an occlusion in the LAD, then they could develop a right bundle branch block. Oftentimes, right bundle branch blocks are considered benign and not as severe as a left. And this is showing you your left. When you have a left bundle branch block, a total left bundle branch block, then what that indicates is that you've got two vessel disease. You've got the left anterior descending as well as the right coronary artery, because those two arteries feed that left bundle. And in order to have a complete left bundle branch block, it means you've compromised blood supply from both of those. And so here is, again, just your electrical physiology and how it fits into, this is your Bachman's bundle that goes over to the left side of the heart, and your internodal pathways, your AV node, your right bundle, and then your left. And you can see the valves here. The Purkinje fibers, that's where the bundle branch blocks terminate in that. And in worst case scenario, those become the final pacemaker when your other pacemakers fail, when the SA node fails, when the bundle of His fails, or you're up here in the junction where your bundle of His is. If those fail to send out the impulses, then your patient can end up with an idioventricular rhythm, and that's coming out of your Purkinje fiber network. So when we talk about the SA node firing, what you're going to see on your rhythm strip or your ECG is your P wave. That tells you that the atria have depolarized. And then when you go down to the AV node, let's see if I can get it to pop up here. Here we go. So you've got your atrial depolarization here, and then your PR segment is the time in which the impulse is held by the AV node. And during that time, the mechanical activity that's going on is your atrial contraction. And then what you have, the impulse coming down the bundle of His, going down the bundle branches and terminating in the Purkinje fibers. And that is what depolarizes your right and your left ventricle. And that's where your QRS complex comes in. And then after that, you're going to see your ST segment, which is the start of repolarization. And then here you've got your repolarization in the T wave. So when you're looking at the total amount, you've got your P wave here, your PR segment, that's when the AV node is holding onto the impulse, your QRS complex, that's ventricular depolarization. Now, during ventricular depolarization, you have atrial repolarization. You just don't see it because the waveform is so small and it's obscured by the large QRS of the ventricles depolarizing. Here's your ST segment. We're going to talk a lot about that when we get to ischemia and injury. And then your T wave is your your repolarization of your ventricles. So when you hear the term vectors, what I want you to think about is which way is the energy flowing? When you have energy that flows from negative to positive, it's going to give you an upright waveform on your ECG. If the impulse travels from a positive electrode towards the negative electrode, then you're going to get an inverted. So vectors just tell you the direction of energy flowing within the heart. So when we talk about a QRS, a couple important things. A QRS is a Q wave is always inverted and it's before the R wave. Okay, you've got to keep these in alphabetical order. The R wave will be positive, and then your S wave is always negative. So if you look down here, I've got 4 different types of QRS complexes. We call them QRS complexes because it's that ventricle that's depolarizing, but they can take different appearances based on how the ventricles depolarize and what lead and what view you're looking at in your ECG. So if you look at A, we don't have a Q wave, but we have an R wave and we don't have an S wave. So if I were to label that, I would call that just an R wave, even though, like I said, we call them all QRSs, even if all of the components aren't there. If you look at figure B, you have a Q wave and you have an R wave. Now, I depicted a lowercase q just because it's a small Q wave. right? And then if you look at C, we have all, Q, R, S. And if you look at D, what we have here is some people will call it a Q wave, or I like to call it a QS complex. And that becomes important if you remember back to the wide complex tachycardia talk that I gave. This oftentimes will signal that it's ventricular in origin, depending on what lead we are looking at on the ECG. So, when you think about it, you think, well, why do I need to look at 12 leads versus just looking at a 3-lead system? So I took this picture off of a 3-lead, and this is lead 2. This is oftentimes what, we as nurses in the hospital like to look at. We like lead 2 because everything's supposed to be upright in lead 2, and it's good for rhythm interpretation, but it doesn't tell us a lot about other things going on in the heart. So it's good for if you want to know what the rhythm is. And if you look at this is the rest of the 12 lead. Look how much more information we get from this. And, I'll go ahead and point out here where you've got ST segment elevation here. You've got these tall, hyperacute T waves. This person's having an infarction and they're having it now. However, if all I had to look at was lead 2, I wouldn't have this information and know what's going on in the rest of this patient's heart. So when you're getting your 12 lead, it's important to make sure that you have your leads in the appropriate place. So this is a nice picture because it shows you, where your leads go, all right? And the V6 is going to go, kind of wrap around. And I always think about V5 and V6 wrapping around the lateral left ventricle. You also have your limb leads. And in the next picture, I'll show you, I'll be honest, the way we used to do it when I was a new nurse, but we'll also talk about the challenges with that. And this shows you the right side where if you wanted to do a right-sided ECG, you can do V4R, 5, and 6. Oftentimes, V4R is sufficient to tell you what's going on in the right side of the heart. And then this picture down here shows you the posterior leads, and we'll talk more about that when we talk about patients potentially having posterior wall infarctions. And you can see here that the limb leads are actually out on the limbs. They can't be on the torso. You want them out on the limbs, but you can see here they are laterally. And in the next picture, I'll be honest, this is how we did it when I was a new nurse. We put them down. We said, you got to put them down on the limbs. But what we found was when we did that, we had a lot of artifact in that. Think about your patients in the back of the squad. Are they moving around? And how well a tracing can you get with your patient moving around? And so that's part of the reason why they've gone to putting them, more proximal on the extremity versus distal. And again, here's the picture that shows the precordial leads, the ones that are in the front of the heart. So don't put them down on the lower extremities distal anymore, just because of the artifact that it was causing. This is your basic, my computer wants to update, but I don't want it to update now. Don't want that to happen in the middle of this talk. So this is the way the sheet is laid out. You've got your limb leads over here, okay? That's 1, 2, 3, AVR, and we'll talk a little bit more about that, AVL and AVF. And then your precordial leads, if you forget about what it means is pre means before, core, the heart, before the heart. Those are the ones that go across the front of the chest. So this is your basic layout. And then you'll have a rhythm strip down at the bottom of the ECG. And sometimes you have more than one rhythm strip down there, different views. So you may be familiar with Einthoven's triangle, and this is looking at your limb leads and your augmented leads. So when you see the A in front of the V, all it means is augmented. The machine makes it bigger so that we can see what that tracing or rhythm looks like better. But lead 1 goes across, and negative electrode is over on the right, and the positive electrode is on the left. So if the impulse travels this way, it should give you an upright positive waveform. lead to, and this is why everything should be upright, is you've got the negative up here and the positive up here. And if you think about the direction of the depolarization of the heart, SA, AV, bundle of His, and then your bundle branches, the normal vectors of the heart travel from right to left, top to bottom. And that's why lead two should always be upright in the normal depolarization of the heart. And AVF, the positive, is down here as well. So AVF and lead two often look at the same area, or they do look at the same area of the heart, and they should be upright. So this is the augmented leads that we talked about. You've got AVL, which is the positive is over here on the left shoulder. You've got AVF down here, and it's going to look up at the inferior portion of the heart. And AVR is over here on the right shoulder. Keep in mind the vectors all go this way. So things are not supposed to travel back this way. And that's why AVR is, or should be, in the normal heart, always negative. Okay, because everything's traveling away from it. So if it travels away from the positive, remember I said it will give you a inverted, and that's why AVR is inverted. These are your precordial leads, and they go around the front and look at the heart. And you can see here that the R wave, look how as it goes around, it gets progressively bigger. We call that R wave progression. And we have what's called transition, where you have equal positive, equal negative, equal R, equal S. That should occur between V3 and V4. So we look to see when is that transition occurring, knowing that in the normal heart, it's V3 and V4. And so you can see here the progression, the R wave gets progressively bigger. And that's because as the leads go around, it's seeing more of that big left ventricle. All right. Because remember, the left ventricle is much bigger than the right ventricle. So it's seeing more of the vectors going towards that. And so 3 and 4 is where you have normal transition. So if we look at this ECG here, take a second and tell me where you see the transition. It goes from a smaller R wave to equal R equal S. And you can throw your answer in the chat if you want. And the reason why this is important is when you have an MI, oftentimes your transition changes. Yeah, I'm seeing the V3, V4. Yeah. And sometimes you have to actually count, but if it's between V3 and V4, you know that that is the correct normal. All right. So if you look at this picture, you can see that the transition is over here in V2, and over here it's over in V5. And so that would be considered a shift to the right, and in this case, a shift to the left. And that would be considered abnormal R wave progression. So again, if you look at this one over here, where's your R wave transition? Where's your transition point? I've got my chat open over here. So if you see me looking over here, I'm just looking to see what people are saying. Yep. I would call it V6. And so that would be certainly a shift to the left. Good job. All right. So how about this one? We'll do one more. All right. So if you said V1 or V2, I would say you're right. And if you remember what the normal looked like in V1 and V2, those are supposed to have really small R waves, and then it gets bigger. So then you have to start asking yourself, why? What's going on? Is there something going on that has changed the vectors within my patient's heart? So when we talk about access, and I've given you a lot of slides on access, but I'm not going to spend a whole lot of detail on this. It's really good when we're looking at trying to differentiate whether the patient has an anterior or posterior fascicular block, meaning that just one fascicle of the left bundle is blocked off. So axis really helps us with that. But it's looking at the total heart and the mean vectors of that. Which direction is it flowing? Because remember, if you have a myocardial infarction, you have what as I call it dead meat. And dead meat don't beat and it doesn't conduct electricity and it changes the vectors within the heart. All right. So you may also have heard of the hexaxial reference system. And so what they've done is they've taken the leads and put it on a 360-degree wheel here. And normal, as I mentioned, is top to bottom, right to left. And so your normal axis is going to be down here in this quadrant. If it's up here, we call that left axis deviation. And up to about -30 is considered a physiologic. But once you get past -30, the more negative it is, from -30 to -90, which would be up here, that's considered pathological left axis deviation. If it shifts over here and is between 90 and 180, that's right axis deviation. And then up here is what we call no man's land, because the axis isn't supposed to travel back this way. It's supposed to travel this way. So this is either severe left axis deviation, no man's land. Those are a couple of the terms that you might hear people describe if somebody has an axis over there. And this just depicts where the normal axis is between -30 and +90. This is your right axis, and some of the things that will give you right axis deviation are listed over here on the right. And notice that, pulmonary things will give you a right axis deviation, or a right ventricular hypertrophy will give you a right axis deviation. Here's your pathologic left axis deviation. And as I mentioned, MIs, left ventricular hypertrophy. If you have a left bundle branch block or a left anterior fascicular block, you will get that left axis deviation. And then a paced rhythm, because if you think about, unless it's a biventricular pacemaker, the pacing wire is down in that right ventricle. So I mentioned the no man's land, and that's the axis up here, and that would certainly be considered abnormal. And we can see that in somebody that has a ventricular tachycardia that originates down here, and the impulse travels upward. So we're going to spend a few minutes just identifying some basic rhythms. So my paramedics, I know you're very good at this. So give the basic EMTs and the regular EMTs just an opportunity, or intermediate EMTs, I'm sorry, to think about it and then throw your answers in the chat. So take a look at this rhythm and tell me what you think. I tried to pick the rhythms that your patient might develop hemodynamic instability. All right, somebody said sinus, and then somebody else said bradycardia. So put them together, sinus, bradycardia. You're correct. You've got your P wave here. It's upright. It looks normal. And this is in a lead too. I'm sorry, I cut that off. So I apologize for not telling you what lead we're looking at. You've got a slow rhythm, and want to know, is this an athlete? Do they know, are they slow? And then ask yourself, are they hemodynamically stable? Because we don't have to treat every slow sinus bradycardia, but we do want to know what's going on with the patient. You might see this in somebody that has some that vasovagals. All right, for many reasons. And you're correct. Somebody said with ST segment depression, you are correct. And it looks like the T wave is trying to flip over. All right. So, but the rhythm in and of itself would be considered a sinus bradycardia, and asking yourself, okay, is my patient hemodynamically stable? All right. So here's another one for you. And you've got your 12 lead up here. All right. And then you've got your rhythm strips down here. And when you're looking at these, all of these are being taken at the same time. All of these are taken at the same time. And that's why you might see something different on this end of the 12 lead than you do at the beginning. So somebody's asking, is this atrial fibrillation? Well, I don't see a lot of fibrillatory waves, but that is a good question. And I do have a nice ECG of AFib that will be coming up. So if we look at this, we actually have two different rhythms in this. All right. So you've got over here, if you look over here, you've got sinus rhythm. All right. And then notice here, look over here. Look at these. Once we get over to this time frame, I want to ask you something. What's missing before the QRS? What don't you see? Yeah, there you go. Somebody said it. You don't see a P wave. All right. Now, what do you think this is? All right. So what's happened here? This person was in sinus bradycardia. Then they dropped into a junctional rhythm. So this is coming out of the junction where the AV and the bundle of Hisson, right in that area, you have pacemaking cells that have capability of pacing the heart generally between 40 and 60 beats per minute. And then the SA node fired, but the ventricles had already depolarized based on the junctional escape rhythm here. All right. So this is kind of an interesting one because when you have a junctional rhythm, you don't always see a P wave. It could be before the QRS, but it could be inverted because it could have been retrograde conducted up, or you might not see it at all because the P wave might be lost in your QRS, or like in this case, where you see it after the rhythm. But this one didn't conduct because the ventricles weren't available for conduction. But you see here again, over here, a junctional escape rhythm, which is not a bad thing because that's better than nothing at all, right? Because if the junction didn't kick in, then all you've got left is your Purkinje fibers. And if they don't fire, then you've got asystole. So you guys nailed that. Good job. All right, take a look at this one. Throw the answers in the chat for me. Okay, so I'm seeing AFib with RVR, AFib, and some SVT. So you know what? You're all correct. This AFib with RVR is a type of SVT when your heart rate is greater than 150. What we can see here, and the reason why we can call it AFib, is look at the irregularity of the R to R. All right, you don't have distinct P waves in front of it. All right, so in this case, the irregularity of the R to R lets us know that it is AFib, and we call it a rapid ventricular response. If it were less than 100, we would call it a controlled ventricular response. So good job. Maybe I made these too easy for you, too basic. All right. So here again, you can see that this patient, if you look down here, you've got a little bit of irregularity in here. So this patient is also in AFib with a rapid ventricular response. So if this patient were unstable, all right, then we would have to make the determination of how are we going to treat this patient? How long have they been in AFib? If we don't know how long they've been in AFib, the danger of converting the patient out of this rhythm is they could throw clots because instead of the atria contracting, they're fibrillating. And so when the atria fibrillate, blood can pool in there and clots can form. So these are the patients that we would go for rate control versus trying to convert them out of this rhythm right away. If we know it's AFib and they are hemodynamically stable. Now, they could be somewhat unstable, all right? And here you can see, slow it down a little bit. And we've got a sinus tachycardia. All right. So this patient did convert. Now, sometimes it's hard to see the P waves, and that's where the beauty of the 12 lead comes in, because you can look in different leads to say, okay, am I seeing P waves here? And you can see here there's a P wave in front of the QRS. So here we've got sinus tachycardia. Do we worry about sinus tachycardia? Well, it depends, all right? Do we have a reason for the sinus tachycardia? Because it's not normal for somebody's heart rate to be over 100. We still need to be asking, why are they over 100? And do we need to treat their pain? Do they have fever? Are they dehydrated? So those are all things that would cause your patient to have a sinus tachycardia. All right. What about this one? By definition, it is SVT. You're right. By definition, look how fast it is. And there's a, when the heart's beating that fast, the danger is it's going to become ischemic, because the heart muscle itself gets oxygenated blood during diastole. So when your heart is beating extremely fast, there's very little time for diastole and very little time for coronary perfusion. So this person might be stable now, but then they could become hemodynamically unstable. Now, if you look down here, we can see that we've got P waves here. So, this person, the type of SVT may be an atrial tachycardia. It's narrow. If they're stable, we can try medications to try to slow it down. We try some vagal maneuvers to try to slow it down. All right, what do you think? If you see that on the monitor, that's when your eyes get big. Yeah, I love that. Yikes. We probably say that too, right? So until proven otherwise, we're going to call this VTAC, all right? So what if I told you that the patient was talking to you? Does that mean it's not VTAC? Can you have VTAC with a pulse? Absolutely. Absolutely. All right. So this patient is in ventricular tachycardia, and let's take a look at his 12 lead. All right. So if you look here, all kinds of tachycardia going on. Wide complex tachycardia. 75% of the time, if you have a wide complex tachycardia that looks like this, it is ventricular in origin. I like to look at V6. If V6 is that QS complex that we talked about earlier, then you can pretty much assure that it is VTAC. Yeah, I like that. Get the pads. Even if they're talking, put the pads on them. Now, I will caution. I've had this happen out in the community where somebody was, having chest pain and they wanted to put the AED on. I was like, no, please don't, not yet. Because, I don't want an AED to shock a patient. But in your case where you are in control, then yes. Oh, I like that, Susie. Lots of diesel. All right. We can bolus them with amiodarone. Amiodarone works on all the pacemakers. So let's say that this was SVT with a bundle branch block. It's still, amiodarone would still work on that. All right. Jet fuel, like it, Lindsay. I don't have jet fuel. Way to go, William. I like that. Okay. Now what have we got? Also bad. Yep. I like that. You guys are nailing these. This is VFib. There is 99.9% chance that this patient is not going to be talking to you. And if they're talking to you, then you've got a loose lead somewhere. All right. So, you've always heard the thing, if in VFib, DFib. Yep. Check a pulse. All right. Because if this person has a pulse with this rhythm, then I check the leads. All right. So good job there. Ventricular fibrillation. We're going to defibrillate them. All right. What do you think about this one? Shake the cable. All right, check the patient. Patient's not doing anything. They are unconscious, no pulse. All right, find VFib. So same thing, right? If you have coarse VFib like you have up here, or if it's fine VFib, then it's it's a shockable rhythm. All right, those are shockable rhythms. If it's flatline and asystole, there's no electricity to interrupt. All right, so we're not going to shock asystole. But if it's coarse VFib or fine VFib, then yes, defibrillate your patient. So I want to spend the last 10 minutes going through some patterns of ischemia, injury, and infarction. I want to allow time for your questions. All right. So let's talk about ischemia, injury, and infarction. Look at, first of all, at your T wave. Your T wave is normally upright. If you have symmetrically inverted T waves, I like to call them arrowhead, then you need to consider that this is an ischemic pattern and ask yourself, okay, why is this patient ischemic? Do they need oxygen? Is the demand too high? Is the supply too low? So look for what I call arrowhead T waves. All right. Not all T waves are symmetrical. So if you look here, if you look under the line, I like to put a piece of paper or draw a line there. If it looks like an arrowhead, I'm going to call it ischemia. However, if you look at this one on the bottom right, it slopes down. I have abnormal depolarization. If I have abnormal depolarization of the ventricle, I'm going to have abnormal repolarization. So it's not uncommon to see that in somebody that has a bundle branch block or has a pacemaker. Because remember, I said the pacemaking wire is generally in, excuse me, the right ventricle. So if I have abnormal depolarization, I'm going to have abnormal repolarization, and oftentimes I have a asymmetrical T wave inversion. That is not indicative of ischemia. All right. Important to look at your ST segment because that's what we use to gauge injury. So if you look over here, this is your normal. I like to use the PR segment as my marker because remember I said the PR segment is where no energy is flowing through the heart. The AV node is holding on to the impulse. So my ST segment should be in the normal heart, even and at the same level as my PR segment. If it's not, then I have to ask why. So if you look here, you can see that it is depressed. And remember, I said earlier that you can have ECG changes because of medications, not used often, but some of your older patients may be on digoxin. And what that will do to your ST segment, it almost looks like somebody took an ice cream scoop and scooped it out. So that would not be indicative of ischemia. Right here, ST segment elevation, and that's the one that we need to really have our eyes open for because ST segment elevation above this isoelectric line is indicative of injury. It's gone past the ischemia and now you've got injury. And if we don't restore blood flow to that heart muscle, then you're going to have infarction. So prolonged ischemia can lead to injury and infarction. And if you look over here, you've got here's your ST segment, and it's way up here. It's kind of merging with that T wave. And I'm going to talk a little bit more about that soon. But if you look here, again, here's your ST segment elevation above the baseline. ST segment elevation above the baseline. And that would be indicative of injury. And if we don't restore blood flow, this patient's going to have dead meat from the infarction. And I don't know if you're familiar with Mary Conover. She put out this many, many years ago, but she talked about smileys and frownies. And if you notice over here, the ST segment is severely elevated and it almost looks like it merges with the T wave. And if you draw two eyes and circle around it, then it's frowning. So if your ECG is frowning at you, that's indicative of injury. And these are the patients that we need to get to a PCI capable facility. So take a look at this one. And you can see here, you've got ST segment elevation here. Look at these ST segments. Right. And this has progressed to the point where you've got your T waves that they were initially probably hyperacute and they have inverted here. But this is a really bad prognosis. And, I always like to say rip when you see that, when you see those tombstones in there. All right. So other things can cause ST segment elevation. When you see it, your first thoughts should be MI, but you may be told that, you know what, this is not an MI. We didn't rule it in. There are other causes for it. Hyperkalemia can give you those tall tinted T waves, and I've got an ECG. I'll show you that. If your patient has pulmonary embolism, all right, somebody that was in AFib that through a pulmonary embolus could develop ST segment elevation, and you might also see it in severe hypothermia. So this is one that is potassium, and look at these big T waves. Look at how they are hyper acute, and notice that it's throughout all the views in the heart. All right, so that gives you a clue that it's a potassium, and then get a good history on your patient. All right, maybe they are a dialysis patient and they skipped dialysis for a couple of sessions. Then we can pretty much guess that it could be hyperkalemia here. All right. And here, what I want you to see is your ST segment elevation. Look at this. You may have heard people talk about fireman's hats. If you look at the fireman's hat from the side, this is the plate, and then this is the main part of the hat going down. You've got ST segment elevation 2, 3 AVF. Okay, that tells me that it's an inferior wall MI. And then I have what's called reciprocal changes over here and over here. That tells me that this is a pretty fresh MI because reciprocal changes, you'll only see those usually within the first 2 hours of the onset of symptoms. And then the reciprocal changes may disappear and you've got ongoing ST segment elevation. All right. And again, I'm just putting the lines there. So this is just to take a mental break. I don't know if you've ever seen these little brain teasers before, but if you have and want to put the answers in the 2 down and 2 up, am I possible? Yeah. All right. Crossroads. Yeah. All right. So what's the other one? You got crossroads. What's this one? There you go. Heather got it. Backwards glance. So just a little fun something to give your brain a quick break. So now let's look at some MIs and where you might see your MIs. So this is just kind of a color code if you're a visual person to help you with that. So localizing the MI shows you the different areas that you can look at and what part of the heart is the problem. I cross out AVR because remember everything in AVR is negative and it's not helpful for that. All right, this is your layout. And if we put our pictures or our colors in here, then you can see where on the layout. Usually V1 and V2 is considered septal, and then V3 and V4 your anterior leads. So somebody asked about high lateral and low lateral. All right, I always tell people, think about where the positive of the electrode is. So for lead 1, remember I pointed out the positive electrode is over on the left shoulder. AVL is over there too. So it's looking down at the high lateral part of the left ventricle, whereas V5 and V6, if you think about where they are on the chest, then they are looking in at the lateral part of the ventricle, and that's the low lateral of the ventricle. Okay, so that's the difference between high lateral and low lateral. They look at just different parts of the lateral wall of the left ventricle. So take a look at this one. And I know we're getting short on time, so I'm going to click through some of these quickly, and then I want to get to your questions. So if you look here, you've got, oh, I don't know what I did there. Let me see if I could. My computer just crashed. Well, let me stop sharing and see if I can get it pulled back up.
I think I think it might be doing a forced update. I hope it doesn't, but if we lose you, we'll know why.
I told it no, but well, dang, it looks like it is. Well, it was time for questions anyway. What I can do is I've numbered the ECGs. I can give Greg, I'll do the numbers and I'll tell you what they are. Would that be helpful to you? I can see all of you on my screen now as my computer is attempting to reboot. Well, I'm glad it didn't do it earlier. What I was going to be going through is just showing you different ECGs and showing you what part of the heart. If you really wanted to get into it, then, oh, wait, maybe. Let's see if I can pull it back up.
Yeah, it looked like it was a Microsoft update, so it might have just been your PowerPoint.
Huh. All right. I may have to share again.
Yeah, that's fine. Yeah, we've got about 5 minutes left, so.
It is all over the place. All right, let's see. Let me pull my Zoom back up. Feel free to go ahead and put other questions in the chat. Let's see if this will, let's see, share screen one. It says I'm sharing.
Thinking.
Yeah.
All right, there we go. We're looking at all of your slides, but there
All
you go.
right. How about that one?
Okay, we got you.
All right. So let's take a look at this one. If you look at 2-3 and AVF, again, do you see the hyperacute T waves? Those occur really early when somebody's having an MI, but you've got this ST segment elevation, you've got reciprocal changes here, and you see reciprocal changes over here in V2, V3, and V4. So, this patient is having that inferior wall MI, and that's going to be related to the RCA, if you want to know what artery. So take a look at this one. And you can see over here in your anterior leads, V1, V2, V3, V4. Look how big those T waves are. Those are called hyperacute T waves. Okay. We don't have a Q wave MI yet. But if this continues to progress, then what's going to happen is those T waves are going to flip over, kind of like puppy dog ears when they are relaxed. And then you're going to lose your R wave and it's going to develop into a Q wave. We know it's early because we've got reciprocal changes over here in leads 3 and AVF. So these are your septal leads, and this is your anterior leads. That's anterior septal, and that would be LAD. All right. Again, look over here. You can see we could draw eyes and put that not smiley, frowny face up here. So this is another one where and the little pictures just show you what part of the heart and the vessel that's involved here. So this patient is having an acute anterior septal MI. All right, if you look over here, then we've got 2-3 AVF, right? And one of the ways that I remember those is it's low and it's inferior low. Right? All of these have positive electrodes down here, and they look up at the inferior wall of the left ventricle. And if you look over here, you can see the ST segment depression, and those are the reciprocal changes that I've been talking about that occur early when somebody is having an MI. All right, so here's your next one. I'll go ahead and show you. This is a pediatric patient. All right. So if you're thinking, I don't see too much abnormal, then you're right, So if you are taking care of pediatric patients, then, at least you have that. But what I wanted to point out here, I've talked a little bit about access. If you look at this, it says QRS. And then over here, you see the axis. You get your P wave. The one that's in the middle is your QRS axis, and it tells you that it is 100 104 axis. So remember, that would be considered a right axis deviation, which is a fairly normal finding in a pediatric patient. So I just wanted to throw that out so you would have a point of reference there. And here, if you look over in your leads over here, you can see that you've got inverted T waves. And look at this, you've got transition here, but you've got these inverted T waves. So it may be that the patient has had some ischemia going on. I'm going to skip ahead because I want to get to this one. Because remember, I said you can't always trust the reading. Look what this says. It says atrial flutter with slow ventricular response, and it's giving you a heart rate of 32. So you can't always believe what the monitor tells you there, because this is definitely faster than 132. It may be AFib or aflutter, but it's definitely not a slow ventricular response. And this is another one where you've got your hyperacute T waves over there. And I want to, oh, I must have gone through it or skipped it because I did not show you the right-sided ECG. I think when I brought it back up, I missed it. So let me back up. Here we go. All right. So if you do a right-sided ECG, the time to do that is oftentimes if you have an inferior wall MI, then they are at risk for having a right ventricular infarction. So look at V1. If you have ST segment elevation in V1, then you will probably want to do at least at minimum V4R. And you have a couple of options. You can move V1 down to the same position on the right side of the chest. And what you would look for is ST segment elevation in V4R to tell you that you have a right ventricular infarction. And for those of you that are ALS providers, you know if that's the case, then you don't want to give nitroglycerin because you could severely drop their preload. Now, if you want to know if they're having a posterior wall MI, then you can bring your lateral leads across to the back, and you notice here's your scapula. The lead goes right here. You can move V5 here, and then V6 would move here, and then you would relabel them V8 and V9. So here's your spine, and then V9 goes just to the right of V8, and V8 would be at the bottom part of the scapula. You would run your ECG, make sure you relabel them, and you're looking for ST segment elevation to tell you that you're having a posterior wall infarction. So I'm sorry I skipped that when I brought the slides back up. And I think with that, I'm going to stop sharing my screen, and let me get my chat back up to see what questions you may have, or if you want to unmute yourself, you're welcome to do that. And tell me, tell me what you think, or hopefully you learned at least one thing that's new. Started off very basic, and the only way to get good at this is to keep practicing. I encourage you to do your ECGs, look to see what it's telling you. And then if you aren't sure that it's reading correctly, because remember, you can't always trust what it says, ask the provider or ask the attending or whoever you're showing it to in there to go over it with you and teach you, because the more you look at them, the more you learn. Every time I go and take a class in 12 leads, I try to pick up at least one new thing that I can then apply in my clinical practice. So I hope you found this helpful. Feel free to email me, and like I mentioned earlier, I'll type up like a cheat sheet for the ECGs that I've given you, and I'll put the number, the slide number, and the number that's on the ECG, and just give you a quick interpretation looking at ischemia, injury, and infarction. And if you want me to include axis, I can do that, because that's a quick, easy thing to put on there. What questions do you have for me?
I think that's it.
Well, then I think I ended on time.
We started a little bit late, so you're right on time for an hour, so that's great. All
We're
right,
close to on time.
yep. Thank you very much, Beth. I really appreciate it. Everyone, I think I have everybody recorded as being here, so
Quick
thank you all for
question.
joining us.
Okay.
Yeah, go ahead.
So when you're looking at the ECG and you're trying to determine VFib from asystole, and you look at and you think it's like 5 VFib or asystole, what's the best determination for that?
Um, that is really a good question because sometimes it's hard to tell. If you think it is fine VFib, you could attempt to defibrillate it. Um, the challenge is if it's truly asystole, then you're delaying the other therapies that you would normally do for asystole. Does that, I don't know if that makes any
Hmm.
sense.
Hmm.
If you already have it on, say you just shocked them and they were in horse VFib and you shocked them and they went into looked like fine VFib or asystole, then you're going to do your CPR. You're going to give your medications, and if you're calling it fine VFib, then you should defibrillate the patient. But I would not keep defibrillating the fine VFib if it could be asystole. Asystole generally doesn't have much there. The one I showed you had a little bit more squiggles than what I would normally see in asystole.
Gotcha. Wonderful. Thank you.
Other questions?
Wendell Lowe asked, is there any time where the hip placement of ECG limb leads are contraindicated other than denial for the patient?
I can't think of anything that it would be contraindicated. We started putting them higher up on the extremities mainly because we were getting so much artifact that it almost rendered the ECG useless. I hate to call it useless, but when you get a lot of limb artifact in there, it is really hard to interpret what's going on with the ECG. And I think putting them higher up on the extremities has helped with that. That was a good question.
All right, any other questions?
Beth, I happen to notice that somebody else asked a question about placing V1 and V2. They were taught to place it in the second intercostal space versus the fourth intercostal. And that caught my attention because a couple decades ago when I was working in an ED and I was doing a 12 lead, I had a nurse come in the room and just sort of rake me over the coals because my V1 and V2 were in the fourth intercostal space. And she was the senior person there, and she insisted she ripped them off the patient's chest and stuck them in second intercostal, but I'd never heard of that.
Mm-mm.
So, yeah,
That's not been my practice over the years. It makes sense that they would be down here when you think about what you're trying to capture, as far
yeah,
as where the heart is placed, the how it is tilted in the chest, and really trying to look at the ventricular septum. If you have them way up here, your ventricular septum is not up here. I mean,
right.
if V1 and V2 look at the ventricular septum. So up here, I don't know of anybody's septum that's way up there.
Yeah, so that's probably just an error on somebody's part with teaching or
Yeah,
not an old practice, or it's just,
I would agree with you, Lori, on that one.
thank you. I just saw that question. I thought we should definitely see if there's any history behind that or what the deal is.
Yeah, I mean, you have to say, well, what am I looking for? And V1, V2 look at the ventricular septum. So you need to put it where the heart physiologically is.
Right, not behind your clavicles.
Yeah.
Somebody asked if a prosthetic hip would interfere with the ECG.
Oh, a prosthetic hip.
I wouldn't think so.
I've not heard of that happening.
My mom had a prosthetic hip and it never did. She's has normal EKGs.
Yeah. I mean, I can't
It's
think
interesting.
that it would cause electrical interference because the prosthetic hip in and of itself is not conducting electricity. Now, if somebody hears differently, please let us know. But just logically thinking it out, that would be my answer to that.
Sarah had a question. If the patient is having a lot of wheezing or respiratory distress and coughing, do you think you would get less artifact with limb placement instead of closer to the torso?
That's a good point. I guess you could if you can. The absolute ideals is going to be try to catch them in between, which is not always easy. But if you think about it, if you're coughing, you oftentimes your whole body and your limbs are going to move. And I don't know, does anybody else have any experience with that they've noticed? Maybe you can unmic yourselves and offer your personal experience with somebody that was having a coughing fit. Maybe wheezing shouldn't interfere with it because that's bronchial. But somebody that's actively coughing, I could see where that could cause some artifact, but I could also see them moving their lower portions of their limbs.
Wendell had a question about using the rough portion of the paper on ECG leads to prep the skin prior to placement. I haven't never heard of that, and I'm not sure which rough part of the patient of the paper.
I guess it's if you're not getting good contact because they're diaphoretic, might dry it off some. But I don't know of any, I don't know that, usually somebody has enough oil on their skin that it would impact it. Usually it's somebody that is severely diaphoretic because they're in the process of having an MI that might impact how they actually stick. And then you're going to get artifact because the leads are not sticking well.
Beth, I do know that some of the leads that we use, if you look at the paper that they're on, they have like a blue or a green stripe on one side.
Mm-hmm.
And that's usually a little bit harder. And I was taught that it's used to kind of scrape the skin to get the dead cells off so the contact is better. That's what I was taught.
Yeah, I mean, I could see somebody teaching that, but
Same here.
my thought process is there going to be enough dead cells there to interfere, or if you cause abrasion, then you risk the potential of introducing bacteria into the patient's skin.
Hmm.
How often does that happen? I don't know. Sometimes we have some sacred cows that we follow. So I don't know that it's necessarily harmful, but I would not rub it until it's red, or if you can quickly.
No, it's more like I was taught just to like, swipe that side like a couple of times, not like put a lot of pressure. Who
Yeah, I
knows?
mean, is it as long as you're doing no harm? I see no harm in it. But if you're doing it hard enough to abrade the skin, then yeah, that's probably not a good idea.
Yeah.
If they are, wet, I think just drying them off would be sufficient if they're diaphoretic.
All right, I'm gonna give some people their evenings back. So thank
All
you all.
right.
Beth, thank you. Guys, if you've got more questions for Beth, please reach out to her. Her email's at the bottom of the slides that you got. She's also CC'd on the emails that you guys got for the for tonight's session. So if you need to reach out to her, she's happy to answer any questions that you have. We are still planning for our next VILT in February, so stay tuned for that. If you're not already on my mailing list and somebody sent you this one, feel free to email me back and ask to be added to the list. But thank you guys so much for coming. Beth, thank you so much for taking your time this evening.
Oh, my pleasure. You guys have a great evening. Thank you. Appreciate your participation.
All right, have a good night, everybody.
Thank you.